I'm Stephen Freems. I'm a professor of surgery in Toronto, and I'm very pleased to be here at the 10th ICC, and it's finally in London. Co-hosts here are Jennifer Lawton from Hopkins in Maryland, US, and Sarah Pereira from Utah in the United States. And Sarah will be talking first on CABG outcomes in women and non-Caucasian patients. Thanks.
Great, welcome, Dr. Frames, Program Committee, Dr. Torregrossa, and Gaudino. It's a real privilege to be here. I am truly very honored to be here with giants in our field that I have admired for so many years. In full disclosure, I am a consultant for Edwards. My only relevant disclosure is that I do chair the STS workforce on diversity, equity, and inclusion. I'm personally passionate about these topics. So over the next 10 minutes, I have a big assignment, which is to speak to you all about CABG outcomes, not only in women, but in non-Caucasian patients throughout the STS registry. We'll talk a little bit about operative and conduit considerations, representation in clinical trials, and then I wanted to introduce our newest working group on social determinants of health that we formed this year through STS. I wanted to start with showing you all the increasing diversity in the United States. This is different than the United Kingdom. So the United States is actually rapidly diversifying. The Caucasian population has decreased 6% in the last 10 years since the 2010 census, and the Caucasian population is now 58%-ish, while as our Hispanic and Latino population, which is part of my heritage, has grown 2 to 3% up to 18%, and our African American population has remained relatively stable at 12%. In the UK, the Caucasian population is 83%, to give you some idea, with about less than 1% Hispanic and an African American population of 3%. So I think this is important because it does reflect the patients that we treat. Importantly, the 2021 ACC-AHA SKY guidelines for revascularization addressed known disparity of care for our patients, and now included as a Class 1B recommendation to reduce disparities of care for the heart team treatment of patients who require revascularization. It's now a Class 1B recommendation to treat patients equally, regardless of sex or race, ethnicity, to reduce disparities of care. And in patients within our heart teams, we should consider cultural beliefs, health literacy, and social determinants of health. So one way to look at disparities of outcomes within different populations is to look at really two indices that I was going to introduce based on these two STS-led papers. The Distressed Communities Index is a measure of social indices such as unemployment, education level, poverty, and income based on zip code. This has been criticized as zip code is so nonspecific. However, a Distressed Community Index greater than 75 indicates a severely distressed community. So this was an analysis by Mahaffey and colleagues of all CABGs performed in the STS database over an 8-year period. And patients with a DCI greater than 50, which is actually a moderately distressed community, had higher risk of adverse effects, morbidities, and mortalities after coronary bypass surgery. If we look at median DCI scores amongst race and ethnicity, we see that Black, Native American, and Hispanic populations have higher scores, with a mean score in the African American CABG population of 73.6, which places them at severe distress really at the beginning. Native American and Hispanic populations also had higher median DCI scores. Also important in this study is that if you look at the communities with severe distress, minority populations had DCIs greater than 75, with a significant portion of the population. And women also made up severely distressed communities at almost 30%. Another way to look at socioeconomic factors within outcomes for CABG is to look at the Area Deprivation Index. And this is a composite score, which does not include zip code, but includes socioeconomic factors such as neighborhood, geographic blocks. And within this STS-based study that was also linked to the New York State database, Hannon and colleagues looked at the Area Deprivation Index, separating patients into quintiles based on ADIs and the New York State data. And patients in quintiles 4 and 5 represented the most disadvantaged patients by ADI. They had higher 30-day mortality when adjusted for age, gender, BMI, and comorbidities such as peripheral vascular disease, lung disease, and heart failure. And women represented the highest proportion of quintile 5, where there were the most women in that group. Of 30-day readmissions, when separated for race and funding source, readmissions were highest in Black, Hispanic, and Medicaid patient groups. So gender differences in outcomes after bypass surgery have been really well described over the last 10 to 15 years. Dr. Adino and colleagues at Cornell have obviously presented huge amounts of data on this topic. This was a large early meta-analysis presented by Dr. Robinson, looking at 84 different studies with almost 1 million female patients. And women had known higher operative mortalities as well as late mortality, major adverse complications, myocardial infarction, and stroke. This was an important retrospective analysis within the STS database over a 10-year period by Dr. Godino and colleagues. And within the CABG data in the STS in the United States, women make up 24.5% of patients. They do tend to be older with a higher incidence of hypertension, diabetes, lung disease, as well as stroke. And there are more African American women within CABG patients in the US at 11.8%, which is consistent across numerous studies as compared to men at 6%. And the mortality for women increased over the course of this study. It's interesting in these graphs here that women are the yellow-orange line, and the mortality is consistently higher across the 10 years. But the operative outcomes actually and mortality peaked in 2020 during the early COVID pandemic with the gender women's mortality of up to 3.3% as compared to male CABG outcomes mortality, which is consistently less than 2%. This is a recent report from the STS Research Committee, which shows the incidence of multi-arterial grafting in the United States. They looked at bilateral internal mammary artery grafting versus radial grafting versus single artery Lima-only grafting, and you can see the numbers based by male, gender, and race in these columns. The data on the right is the single arterial CABG group. There were more women in the single arterial CABG group and less minority patients. It is good to know that this includes over 1,000 centers that reports the STS database, and only 14% of patients overall had multi-arterial grafting. The bilateral mammary grafting overall is only 5.6% in the STS database, which remains entirely too low. And the radial grafting is at 8.5%. Women and Black patients received more single arterial grafts, with only 6% of patients in that group Black, as opposed to 84% Caucasian. This was a non-gender specific study, but a very large study presented by Joe Sabick last year and recently published in the Annals of Thoracic Surgery. This was a 10-year follow-up of over 1 million patients in the STS adult cardiac database over an 11-year period, 1,100 programs. And the annual overall usage of multi-arterial grafting throughout these 10 years ranged anywhere from 8 to 12% max. And at 10 years, multi-arterial grafting was associated with improved unadjusted and adjusted 10-year survival over nearly all demographic barriers. The details of the specific race and gender breakdown is not provided in the manuscript. However, patients with a high BMI greater than 40 were the only patients that did not exhibit the improved survival over 10 years. Patients greater than age 80, New York Class 4, poor kidney function, and vascular disease also didn't have a significant survival advantage at 10 years. This is one of the most important papers presented written by two of our co-moderators, Drs. Lawton and Zwischenbergen, looking at sex differences in CABG. And we really, in this paper, looked at the overall usage of multi-arterial grafts and LIMA with bilateral mammary versus radial grafts. You can see how low the percentage of multi-arterial grafting in women is. But not only was the usage of multi-arterial grafts low in women, that women had a lower usage of left internal mammary only grafts at 93.9% than men. The incidence of BEMA use was 2.9% and radial just 3%. Women also consistently were older, African American, smaller, and had lower hematocrits, what we'll talk about in this session. And you can see in the graph on the right that even though bilateral mammary and radial utilization rates rose in both genders throughout these 10-year periods, they still are really under 8% for even men in this data set. The differences in bilateral mammary use as well as just LIMA alone use applied to women as well as race. And in the multivariable logistic regression model here, women, Black, and minority patients all consistently were less likely to receive multi-arterial grafting and usage of LIMA alone. They also were less likely to have complete revascularization. This was a recent pooled analysis by Dr. Godinho and colleagues that I thought we should point out. It really looks at graft failure specifically in women and by gender, and it's a pooled analysis of patient data from 7 randomized controlled trials. These are not just US trials. I think 2 of these were US trials and the rest international. And the median time to post-operative imaging was 1 year, but graft failure occurred in 37% of women at 1 year. The mean number of grafts was significantly lower in women at 2.9 grafts per patient, with multi-arterial grafting usage of 6.3% and bilateral mammary usage of 3.6%. And importantly, the off-pump CABG rate was 25% overall throughout all of these trials. The REMA was the highest failed graft at 33%. Which over my career, I have used a lot less REMAs for this reason and prefer radials. And the radial failed grafts were the lowest at 11.8%. Overall, female sex independently was associated with graft failure. So disparities in representation in clinical trials, we all think are very important and a known issue. Most of our clinical trials range from 10 to 20% female patients. Rania Provenza and her group in Texas at that time looked at sex, racial, and ethnic disparities in US cardiovascular trials, and this was over 180 trials, of which 85 of these were CABG trials. They looked at the patient to prevalence ratio in these trials, and anything less than 1 is underrepresented. Anything greater than 1 is overrepresented in the trials. And you can see over the quintiles of 4-year periods where men are in blue and women are in maroon, where women are consistently less represented in clinical trials, hopefully with the exception of Roma, and men have been increasingly represented. And if we look at funding for these trials, this is in the US, we'll see that funding consistently for women in trials and participation is low. The third graph where the US federal trials are the VA-funded trials, of which we know that there are few VA female patients. And then significantly the same in the trials, racial and ethnic distribution of patients is low. Men are in green, women are in gray, and Asian patients are in yellow. Asian patients tend to be overrepresented in US clinical trials, whereas women are underrepresented. And if you look at Hispanic patients versus non-Hispanic patients, Hispanics are in orange. Hispanic patients are consistently underrepresented. And lastly, I could not give this short talk without a plug for the Roma Women's Trial. Thanks to Dr. Godino for these slides. As you know, Roma has been enrolling now since April of 2023. The goal is to enroll 2,000 women randomized to single arterial versus multi-arterial grafts with a second arterial graft, either the REMA versus the radial to the lateral wall distribution. This slide is a little bit old. We do have close to 70 sites now, I believe, internationally in the Roma Women's Trial. And as of February, Roma Women's had enrolled much higher than expected. There were 642 patients, and I think it's closer to 1,000 now on our last call. And lastly, I wanted to mention the RECHARGE trial, which has just started enrolling. The RECHARGE trial is important as it will enroll women as well as Black Hispanic patients to either PCI versus CABG when there is equipoise for either, and the goal is to enroll 1,100 patients in the US. So the Society of Thoracic Surgery recognizes a disparity of care, and with support from STS leadership, we have formed a working group on social determinants of health as of March of this year. We have a representation from cardiac surgeons, thoracic surgeons, and congenital surgeons with the goal to identify risk factors and socioeconomic determinants that contribute to adverse outcomes. What should we look at? Should we look at the area deprivation index or distress community indices, or are there other better things? We'd like to incorporate these metrics into the adult cardiac database within STS and our risk models. And really within 9 short months, these are the abstracts that have all been put together by our members to be presented at STS in January. And thank you. It's really an honor to be here, and I appreciate all of you.
Thank you so much. I think we'll have a panel discussion at the end. If you could please hold your question. Thank you.
So I'll introduce the next speaker, Dr. Kunal Sarkar. Is he here? Yes, very good. So he's going to talk to us about surgery in the Indian subcontinent. Very nice to see you again.
Thank you for the opportunity. So even though in the titles the geography kept on varying time and again, so we have stuck to CABG in the perspective of women in South Asia or the Indian subcontinent. You see, coronary artery disease, which is very closely related with metabolic syndromes and diabetes in the Indian subcontinent, remains a very nasty disease. It has high mortality rates, one of the highest contributors to premature mortality. The disease burden is increasing, and even in our countries, there is a marked regional variation. If we look at the escalating ischemic disease burden amongst women, say in India, compared to, if you just compare the geographies of India and China, these are 2 parts in the world where still the disease prevalence and the impact of this disease on mortality is on the increase in distinction to the rest of the world. And increasing diabetes remains a big worry. And in the South Asian medical conversation, malignant coronary artery disease in women is a very accepted physiology today. Cardiovascular disease contributes to 25% of our overall mortality, and we will discuss in a few slides at the end how seriously we are underserving this disease, and we must confess that in our region we suffer from an inadequacy of data. CAD, coronary artery disease in women in South Asia, is a different kind of disease. It is not only related to what we do later on in life, but there is a lot of work which has come out of India to prove that poor maternal health, intrauterine growth retardation, and decades of repetitive famines that followed in the subcontinent from the colonial era contributed to the premature incidence of diabetes, which in subsequent generation is manifesting in the coronary artery disease spectrum. The premature activation of the diabetic genes in the South Asian population has to be noted. And this disease in our people starts even before we are born. There are studies which are not really very well standardized, which tells us that probably the size of the epicardial vessels in our population may be a little smaller than that of the Caucasian comparatives. But this is a very heterogeneous data, some from coronary angiography, some from CT angiography, so you end up comparing apples with oranges. Are Asian coronaries, especially that in women, more spasmogenic? There are some sparse data to substantiate this fact, and that is why, stress tests like treadmill tests, etc., are not very well relied upon in our parts of the world, and we do not do them very often. There has been attempts. There has been a couple of publications, especially from Canada, from Toronto, who have experience of operating on a good number of South Asian patients. And there was one data which said that they gave the South Asian ethnicity as a high-risk marker for the outcomes, and the odds ratio were higher than 3.1. And shortly afterward, from Dr. Freem's group, another publication came out of Canada which completely contradicted the previous findings and said that, of course, that was not the fact, and there was very little difference noted whether the patients were South Asian or not. So it remains an unsolved entity. From our part, from India itself, we do not have a whole mass of registry data. The largest series that has been published really comes, the author is sat right in front of me, which looked at more than 13,000 patients, and they were of the conclusion that the female gender did not contribute adversely to the outcomes. We have some smaller publications from Pakistan, which looks at about sample sizes less than 2,000 patients. But like ourselves and Pakistan haven't agreed on much over the last years. And over here, there is a little bit of disagreement. They seem to think that female gender was a high-risk marker in their population. Over the last few years, a group of surgeons from India, the Society of Coronary Surgeons, have been contributing to the STS database as a separate pool. And when we wash our contributed data to the STS database in little less than 8,000 cases, we find out that we have done 23% of women. Early mortality was around 1.2%, not greatly different, 70% off pump, and the left internal mammary usage was around 85%. Small numbers, but still a little bit of data to show for. There are other papers which do show from the All India Institute that women did not do too badly as far as their rehab was concerned. But What we want to tell you is if you took a synoptic view, then in India, the percentage of women were in some series varied from 25 to 30%. Overall, we are of the opinion that the female gender did not contribute adversely, but much of the other data from other countries of South Asia is really not very robust at this point. But what is perhaps of more importance in the last minute or so is if we look at the coronary surgery activity in our part of the world. So India is performing around 260,000 surgeries per year, closely matched by China, around 240 to 250,000, and the others are shown over here. What does it mean in terms of the procedures performed as per capita as vis-a-vis the population? Japan stands exceptionally at around 600 procedures per million. The rest of all, you cannot do justice to the CABG in women if we are not doing justice to the disease burden overall. Now, just see that in the annals of thoracic surgery last year, year before, there was a publication from the health epidemiologists, which vis-a-vis the income status of the country, the healthcare infrastructure available in that country gave us desired indicators what we should be doing. We were divided into low-income, mid-income, high-income groups. I will not go into the details, but this is the extent of underperformance. India today performs 170 surgeries per million. We should almost be doing twice the number. In a few years' time, when we get kicked up and being called a high mid-income group, the disparity becomes even worse. So even in the next decade, we will not be performing even half the surgeries we are supposed to perform. And China, even the next sort of the high procedure country in Asia, China, has a similar problem to grapple with. China currently is even performing less than half. China is a high income country, which is currently even doing much less than what it used to. So this remains a singular challenge in the Asian geography right now. Coronary artery disease, in conclusion, in South Asia is on the increase, with high premature mortality, more so in women. Women probably have smaller and more spasm-prone coronaries. Experience from some data in North America seems to suggest worse outcomes in women after CABG. It is not supported unanimously by the limited data that we have from South Asia. India and other South Asian countries have a lot of catching up to do to address the overall disease burden. And I leave you with the thought that we have a long way to go to address the cardiovascular and the coronary disease burden in our part of the world. And can an organization or a gathering like the ICC take up this advocacy forward? So we need more procedures, more data, better outcome. Thank you.
Great presentation. Now, Jennifer Lawton will talk about some of the factors that are associated with the poor outcomes, or may be associated with poor outcomes in women.
Thank you. Thank you so much for the opportunity to present today. Thank you. I'm going to talk about anemia and other determinants of poor outcomes. My disclosure, same as before, I have nothing to disclose. My comments are my own opinions. I'm going to talk a little bit about the worst outcomes in women, some of the determinants and strategies to improve. This is a day in the operating room where everyone in the room was a woman. Many people, patients and physicians are not aware of the fact that in the United States from 1985 to 2013, more women than men died of cardiovascular disease. It is the #1 killer in women, as it is globally. The American Heart Association began the Go Red Women campaign, and on the bottom right, you can see a cover of Circulation Journal, which is the American Heart Association journal. And in 2004, they had the first issue devoted just to determining cardiovascular disease risk in women. So that was 2 decades ago. Women are different from men. Diabetes and anxiety tend to be more powerful risk factors in women. They tend to have disabling symptoms that are clinically relevant and associated with bad outcomes, despite having either small vessel disease or non-angiographically significant disease. They tend to be 10 years older at presentation. They tend to have multiple risk factors and comorbidities at the time of presentation. They more often have an urgent presentation. They have a more severe angina class. They're more likely to have a silent myocardial infarction and to present with sudden death and to die after a myocardial infarction within 1 year. And this is a Time magazine article, Those Fragile Hearts, Who Dies from Heart Attacks? Surprisingly, more women than men. So as I mentioned, they're more likely to have all those things on the previous slide, but they also have atypical symptoms more commonly than men. So they may present with nausea, abdominal pain, reflux, or even just fatigue. They tend to care for others, and that may contribute to their delay in presentation to the hospital and also to delay in treatment. They may put the care of others before their own health care. So they have a longer time to time of admission and treatment for cardiovascular disease. They're less likely to receive guideline-directed medical therapy, and as you heard earlier, they're less likely to receive guideline-directed surgical therapy, including complete revascularization and arterial revascularization. They're less likely to be referred for cardiac catheterization, stress testing, and surgery. And there is a lack of knowledge not only in physicians but also in patients. Physicians tend to assign women to a lower risk category than men, even with the same risk factors. And patients don't perceive their own risk of cardiovascular disease. If you ask a large group of women in multiple surveys, their greatest risk to mortality, and they tend to say breast cancer or something other than cardiovascular disease, so they don't perceive their own risk. And also you've heard the data that we have on cardiovascular disease in women and the way to treat women in the operating room is largely based on clinical trials in men. So the traditional risk factors are on the left side of the screen that we're all well aware of, but on the right side of the screen, many physicians and patients are unaware of these risk factors in women, particularly OBGYN physicians who need to discuss this with patients at the time of childbirth. So preterm delivery, hypertensive disorders of pregnancy, gestational diabetes, autoimmune disease, breast cancer treatment, and also depression, unique risk factors for cardiovascular disease in women. So it's not a new problem. As I mentioned before, it's 20 years since the Circulation publication to determine risk factors and risk at 10 years for cardiovascular disease in women. So it's been more than 2 decades since we've known that there is a sex disparity between men and women. And in 1999, we know people started to talk about how women were less likely to receive a left internal mammary artery graft. So again, more than 2 decades. And evidence-based guidelines for cardiovascular disease were first started in 2004, and I'll show you that in just a minute. But these are some more contemporary data, and you can see from this Medicare beneficiary database in the US, about 1.8 million women. On the far left, in-hospital mortality, in the middle, 30-day mortality, and on the right, 1-year mortality. And you can see in women in blue, over the entire course of this study, they had a higher risk of mortality at each time point. Again, contemporary data in 2020, more than 2 million patients, and this is from the national inpatient sample in the United States. You can see that on the top graph on the right, mortality in women is higher, and on the bottom, women were less likely to receive a left internal mammary artery graft. And even more contemporary, Gaudino and colleagues, this large database looking at sex-related differences in the outcomes after CABG, and this is a pooled analysis of 4 randomized controlled trials. So women had a higher rate of MACE, which you can see here in red, cumulative event rate over the time in years on the bottom. There was no difference in mortality, but the higher rate of MACE was largely driven by MI and repeat revascularization. So what are the reasons for this almost over 2-decade-long difference in outcomes in women and men? What are the contributors? What is the weight of each? Do we know the weight of each? Do they contribute to short-term outcomes or long-term outcomes? Because we know the outcomes are worse in women in short-term and long-term. Could it be related to diagnostic testing? We know that echocardiogram is less specific in women due to body size and breast tissue. I'll show you a little bit about troponin levels. Could it be due to the hospital quality, physician-related, as I mentioned, or other patient factors? In 2003, Colleen Koch and colleagues at Cleveland Clinic first published this gender profiling in coronary artery bypass grafting. And they looked at more than 15,000 women and noted that women had lower hematocrit, lower red blood cell mass, lower BMI, and lower BSA. And it was particularly concerning the lower red cell mass in that the hemodilution during cardiopulmonary bypass could exacerbate this. And this, in 2003, I think the senior author is in the audience, we're one of the senior authors, Dr. Tom Schwann, over 5,000 consecutive patients, and elegantly on the top right demonstrated that survival is related to hemoglobin, and it's intraoperative hemoglobin and operative mortality. And they suggested that the intraoperative hemoglobin should be 22%. And I quote, "We believe that the poor outcomes in these two patient subpopulations would be smaller sized patients and women are directly linked to their relatively more severe dilution of hemoglobin." And then the bottom, you can see both early and late mortality were related to intra-op hemoglobin. And these are the STS guidelines in 2005. Again, 2 decades ago. One of these guidelines, particularly for women, was ensure adequate intraoperative hematocrit levels. And it was a class 2A, level B. Efforts should be made to ensure adequate intraoperative hemoglobin levels. So we've known this for 2 decades, or suggested this. And here in this contemporary database from the STS in 2004 by Gaudino and colleagues, more than 1 million patients, more than 340,000 women. Higher operative mortality was seen here. You can look at the spline regression in the graph at the bottom, the relationship between intraoperative anemia and operative mortality in women, and it was strongest at the nadir, with the nadir intraoperative hematocrit value of 22. So that seems to be the cutoff 20 years ago and then again today. And they found that intraoperative anemia mediated 38.5% of the increased mortality risk associated with female sex. So as before I mentioned, what are the weights of the differences between women and men? This suggests that 1/3 of the differences could be due to anemia. One more contemporary from 2024. This was a paper looking at 30-day mortality by hospital quality. So you can see on the left side, sex, female on the top and male on the bottom, and the density or the color of the square, if you will, is the percent mortality, with the highest being greater than 7% in black, and the range of hospital quality from highest to lowest. And what they found is that female beneficiaries in this study at low-quality hospitals had a greater than 4-fold higher mortality than male beneficiaries at high-quality hospitals, suggesting perhaps many things. Women are more likely to go to low-quality hospitals. Perhaps we should refer patients to high-quality hospitals. A lot of different questions from this paper. And then another 2024 paper looking at troponin levels in women and men, biomarkers in more than 3,600 patients, 17% of whom were women. The primary outcome was MACE at 30 days, including all-cause mortality, MI, and repeat revascularization. And the absolute troponin levels associated with MACE were significantly lower in women compared to men, with a threshold that was normal for both men and women. 23% of women were underdiagnosed with risk or troponin levels that led to MACE. So a large number of women were being missed. Perhaps, particularly if they were a low-quality hospital, for example, they would not have been rescued and would not have been suspected of having a bad outcome. So how do we improve outcomes for women after CABG? We have a lot of things we could address, perhaps preoperatively, intraoperatively, and postoperatively. There have been studies that have mentioned intraoperative, preoperative, and post-discharge hemoglobin are related. So perhaps focusing on that, focusing on the delay in diagnosis, the delay in treatment, education for patients and physicians, remembering angiographically insignificant coronary artery disease also affects outcomes, improvement in diagnostic testing, and we saw some amazing diagnostic imaging this morning. use of sex-specific troponin levels, specialized centers, perhaps that focus on women with cardiovascular disease. And then intraoperatively, what can we do as surgeons? We can use guideline-directed surgical therapy. We can give women all arterial grafting. We can provide complete revascularization when it's possible. Use of transit time flow meter, flow in your grafts after surgery. Use of perhaps smaller suture if the vessels are smaller, and other methods to address smaller vessels, and coronary specialization in our field. Postoperatively, again, anemia prior to discharge, hospital quality and rescue, guideline-directed medical therapy. We had a fabulous talk this morning about the medical therapy that we should be giving our patients, referral to rehab, and use of sex-specific troponin levels postoperatively. Thank you so much.
Thanks, Dr. Loughton. That was outstanding. It's my pleasure to introduce Dr. Rashmi Yadav, who is here at Royal Brompton Hospital. She's going to speak to us and give us all the perks on how to select conduits in women.
Thank you very much. I'm going to share something personal with you. How do I move my slides forward? The green button. I lost my dad just over 2 weeks ago, and in choosing to be here today, I'd like to honor the memory of my father, who was a great supporter of women and who encouraged both my mother and myself to be doctors and surgeons. These are my conflict of interest slides. This is not a slide I show often because it makes me look and feel short. I don't consider myself short, but of course everything in life is relative. And I never cease to be amazed by the biological, morphological, and physiological differences between my male and female patients. And as you can see over the years, repeatedly, women patients tend to be of lower BMI, of shorter stature, and with that comes fragile tissues, smaller conduits, smaller coronary arteries, and I would say that our women patients demand a higher technical expertise. And this talk is partly about that, because you could really trip up at the very first step. I remind my registrars repeatedly that the sternum can be very narrow in a women patient, yet from time to time you get a paramedian sternotomy that then has to be fixed. Here you can see how the phrenic nerve in a small pericardial cavity can be lifted up so much that it is at risk of injury when you're making your window between the pleura and the pericardial cavity. And this, in my own hands, injury to the LV apex in a small fragile heart when rotating the heart. So these are all things one has to be very, very careful of. Here you can see how in a female patient's pericardial cavity you can get an almost a tamponade-like physiology simply because there isn't enough space there compared to a tall Caucasian male where you will easily find an inch of space between the sternum and the right ventricle. This is an old slide, and I often ask people to guess which of these is an artery and which is a vein, but in fact all of these three are cross-sections of the left internal mammary artery. The first panel belongs to a Caucasian male, the middle panel belongs to an Asian male, and the bottom panel belongs to an Afro-Caribbean woman. And you can see why we then have challenges providing even single arterial graft safely to our women patients. And this is also a more recent yet an older slide showing similar differences in size between our male and in the bottom right corner of an Asian female patient. Additional to that, of course, this is a Brompton Hairfield infection score that was developed, and just by being a woman, for no other reason, you gain a score of 2. So that is something one has to consider when choosing a conduit for women patients. So coming to the very simple limit LAD, it isn't just about what conduit, but also about who is doing the operation. And again, with the women patients, there's particular emphasis on making sure that the person harvesting the lemur is very experienced and is aware of the pitfalls. Also, when using the limit LAD, I try as much as possible to do a proximal anastomosis anastomosis. And of course, there one has to be mindful of the pitfall when the anastomosis is very proximal. The lemur can kink if it isn't made completely straight, and therefore I would advocate to my trainees always to make the lemur very short when they're doing a lemur to LAD anastomosis very proximally. Now here's a disease that affects women because, I've got breast cancer here. You can see the patient's had a mastectomy, but what is also visible on this CT scan is that the left internal mammary artery is just not opacifying, and this patient had very little flow down the left internal mammary artery, and I was not able to use it. If this was a non-contrast image, you would have also seen that there was calcification of the ascending aorta. So there are many pitfalls that have to be considered. When considering multiple arterial graft strategies, without doubt, my go-to second graft is the radial artery. There are multiple publications showing that radial artery grafting improves survival in women, as well as there's greater patency. The first paper showed an 80% patency of the radial artery versus a 56% patency of the saphenous vein. And subsequent studies also have confirmed that radial artery is better for women, and one particular study showing that women have a greater advantage from the radial artery compared to men. So radial artery, of course, there's excellent patency. As we know, it's a longer, thicker walled conduit than reamer. There's ease of harvesting, and there is ability to reach all coronary targets. There's also reduced risk of sternal wound infection. And in this image, you can see how a radial artery may be used to do multiple sequential grafts on the lateral wall of the heart. So in an older patient, my preferred strategy in a woman patient is an in situ lemur to LAD. I try as much as possible to keep the internal mammary artery in situ, the radial artery to the circumflex, and for the third target, I would use the saphenous vein to the right coronary artery, but there is a systematic use of ultrasound scan in all patients, and if there's any doubt about the quality of vein, I wouldn't hesitate, even in an older patient, to use a third arterial conduit, particularly the radial artery or a reamer. Also, because in my male patients, I'm particular to use the leg vein during endoscopic harvesting because of lack of side branches, but we often find that in the women patients, the leg vein can be very small in diameter, very thin-walled, and therefore the ultrasound assessment is helpful in choosing an upper leg or thigh vein if that's a better diameter and more thick-walled. When considering all arterial grafting, I do think very carefully about the lemur-reamer Y graft because these are thin-walled, smaller diameter vessels, and there's risk of dissection and stenosis at the Y anastomosis. The in situ reamer to LAD, of course, means that you use the distal end of the reamer, a smaller diameter vessel with risk of spasm, and of course also the risks of crossing the midline. And when using it through the transverse sinus, it may not be long enough to reach your desired target vessel. The free reamer having the problem of being a very small proximal anastomosis diameter. When doing the Y graft, I do intraoperative assessment to assess the lemur thickness and diameter, and if I'm satisfied that the lemur is of good quality, then I assume the reamer would also be good quality, and only then would I harvest the reamer for a Y graft. And of course, I would consider patient age and comorbidities and risk of sternal wound infection. But of course, appropriately performed, this can be a very effective graft also for women patients, but I have to say that this is it's a less common operation in my practice in the women patients. This is another approach of using, we've heard about it already, in situ lemur to LAD, radial artery for the circumflex territory, and then using the in situ reamer with an extension either with the radial artery or lemur for the RCA or PDA. The next few slides are courtesy of Sigrid Sandner, and she has a very elegant strategy of using the in situ Rita to the LAD. And I have to say that until I saw this presentation earlier this year, I was a skeptic about using the Rita to the LAD. But as you will see in this video, with a very proximal dissection of the pericardium and the pericardial fat, the reamer can be brought across very cephalad, very safely across to the left side. The fat is then closed over the reamer, protecting it and making it safe should there be any need for future reoperations. And here you see very nicely the reamer artery anastomosed to the LAD at the mid-level. And of course, one mustn't underestimate the standard limits to LAD saphenous vein graft in non-LAD targets, so a very safe operation for women patients if you're not able to offer multiple arterial grafts, particularly in the older, more frail patients. So I'd like to end with a plea to recognize coronary surgery, and I know I'm speaking to converts and enthusiasts in this room, coronary surgery as a super specialized area, but particularly for women patients in all institutions, there should be people who recognize and put themselves forward as experts in this field so we can offer better outcome to our women patients. Thank you very much.
Could you stay at the podium for the panel discussion, Rashmi? Thank you. And our last but not least presentation is entitled Hybrid Revascularization, Extra Advantage for Women, ? By Dr. Brittany Zwischenberger at Duke.
Hi, good morning. Thank you so much for the invitation. All right. So I'm going to skip to my conflict of interest, which are none. So this is super exciting because last year at the International Coronary Congress in 2023, I got to present about technical challenges of CABG in women. And this year, I get to talk about what to do and a potential solution. So I'm going to amplify several of the points that my colleagues have already made, that there are sex differences in outcomes after CABG for women versus men. Women are sicker at the initial presentation. They have more diffuse coronary artery disease. They have smaller coronary size with increased technical complexity. They have higher rates of anemia, higher procedural risk, and likewise more blood transfusions after surgery. They have lower quality venous conduit, more vein stripping, and lower odds of complete revascularization with an adjusted odds ratio of 0.86 in the STS database. So again, slides that you've already seen that we've already presented for years. Women are less likely to get radial artery grafts, less likely to get bilateral IMA, and less likely to get the IMA and the STS database. They have, women are associated with failed grafts, with more graft failure, and more repeat revascularization in the future. And most recently, women have a higher rate of failure to rescue, which is defined as death among patients with a postoperative complication. So, and then, of course, increased risk of wound infection. So this is a very small observational study, but it did show that women were more likely to have superficial plus deep sternal wound infections with a rate of 26%. So we've successfully described the problem. And so the rest of my presentation, I want to focus on how we can do something different with a new focus for CABG, and that's health equity. So we have this patient, and this patient did great after CABG. This patient did fine, and this one barely got through it. So can we adjust the foundation for all to succeed after CABG? And I'm specifically looking at women today. And so this slide is hopefully going to blow your mind. CABG is not an operation, but a concept. And so how can we give surgical revascularization to women using all of our tools, all of our techniques, from the most traditional on-pump, cross-clamp, multi-arterial, I'm sorry, that's not traditional, but the VIP, the deluxe, the more traditional on-pump, cross-clamp with lima and vein, all the way to one of my passions, which is minimally invasive surgery, thoracotomy on or off pump. So to clarify what we're talking about today, hybrid for women, use minimally invasive CABG. Here I'm using the robot to take the lima off the chest wall, then a small thoracotomy to do off-pump lima LAD with a PCI before or after surgery. And this gentleman, he came to clinic and ripped open his shirt Miami Vice style to show off his incision. He was so proud. But we can also do this for women. So I want to see how hybrid can improve surgical revascularization for women, looking at first quality improvement, looking at what we're already doing, what we already know, and then research for the future. So hybrid has been shown to reduce morbidity in women, or I will propose that it will reduce morbidity in women with reduced blood transfusions, length of stay, and return to full activity. So basically a lot of the components of the earlier talks, but really zoning in on how hybrid addresses this for women. So this is the only study that I'm aware of that looks at hybrid in women with our own Gianluca, looking at women with two-vessel coronary disease. Again, small study, observational, propensity matched, and patients underwent robot hybrid Lima LAD plus PCI, and compared to off-pump sternotomy, two-vessel. There's no difference in the overall survival or target vessel revascularization. But going forward, we have to really put our special glasses on and extrapolate some of the data that already exists from hybrid, which is small, and think about how we can apply that to women. So this is one of the only randomized controlled trials for hybrid. It's a Polish study, randomized control hybrid versus CABG, 200 patients all referred for standard CABG. Women made up 21% of the hybrid group and 26% of the sternotomy group. 6% of the hybrid patients were converted to sternotomy, and they demonstrated similar morbidity and similar mortality. This is an observational study on minimally invasive CABG. It's a single vessel Lima LAD only, either sternotomy or thoracotomy. And with the STS data, the authors demonstrated reduced morbidity and mortality. But specifically looking at post-op blood product usage, which we've already talked about as an issue, and surgical site infection. So both outcomes were favored for minimally invasive. Again, this is men and women. And other observational studies demonstrated that minimally invasive CABG had reduced blood transfusions. So in the study we just talked about, Lima LAD only, minimally invasive CABG to off-pump CABG had an odds ratio of 0.52 with a risk reduction for minimally invasive. And the next study is multi-vessel coronary artery disease, so minimally invasive approach plus op-CAB, 13% for minimally invasive. And then lastly, minimally invasive CABG versus conventional CABG with 12% significantly less. I'm sorry, I miswrote that p-value. And then also looking at quality of life. So the American Heart Association and what Dr. Lawton presented is there's a push for us to look at risk factors associated with poor outcomes with coronary disease, not just the traditional ones, but psychosocial risk factors as well. So for women who are caregivers later to present, minimally invasive surgery is associated with reduced time to full activity. In this one study, minimally invasive 12 days versus op-CAB 5 weeks. And sternal wound infection rate. Many studies, as we feel this in our own practice, off-pump CABG, 2 to 4% risk of deep sternal wound infection. Conventional CABG, 2 to 4% deep sternal wound infection, but the rate of minimally invasive, of deep sternal wound infection for minimally invasive CABG is 0. We are also seeing that you could use minimally invasive to increase your multi-arterial grafting without this increased risk of wound infection. This is Dr. Balke's series, robotic off-pump totally endoscopic CABG, observational study, 24% women, and hybrid with 77% of the patients getting PCI after surgery and 13% before surgery. 89% of the patients had bilateral internal memories, and he demonstrated excellent freedom from MACE over long term. Here Dr. Balke describes all the ways that he uses bilateral IMAs, so we can, again, extrapolate this for women who have an increased risk of wound infection with bilateral internal memories. So new directions for CABG in women, we need to move the needle a little bit, and referencing the Roma study, we've seen that women are very interested in enrolling in these trials because they want to do better for their daughters. Moving on to research. You'll hear more about this meeting, but the REACH-CHARGE trial, 2 parallel-powered, multi-center, 1-to-1 randomized open-label superiority trials. So there's the women group and then the Black and Hispanic group, multi-vessel coronary disease or left main, and equipoise between CABG versus multi-vessel PCI. And they have a novel outcome of all-cause death plus change in generic quality of life survey. And we've also proposed a hybrid nested registry. So this is one of my evil plans, is to increase use of hybrid for women by finding a home for it. So again, these are patients, women, Hispanic or black patients who are eligible for e-charge, but then they're excluded because there's lack of equipoise, and those patients we want to consider for hybrid. So whether they're appropriate for multivessel PCI, and we also consider them for hybrid, or vice versa, they're appropriate for CABG, and we also consider them for hybrid. And this study is a model for health equity research, and it's being supported by the government ending unequal treatment, and they specifically describe strategies to achieve equitable health care and optimal health for all by diversifying the training group, focusing on social drivers, and using patient-centered endpoints. So this is my expanded patient selection for minimally invasive CABG. Certainly, it's evolved over time. So patients with isolated proximal LAD disease, and then patients with multivessel disease or left main with or without hybrid. So that would be for patient preference, poor sternotomy candidates that have frailty with calcified aorta, a patient who presents with a STEMI and gets a PCI to the right or the circumflex and then has residual LAD disease, a patient with non-LAD poor targets or lack of conduit, complex LAD for PCI, and women with these women's issues, so diabetic, obese, smoker, pendulous breast. And I'll end with this patient, 66-year-old female, diabetic, Crohn's disease, immunosuppressed, who had a stroke in the 90s. She was still functional, really not good for anything. And so I did a minimally invasive CABG, and she even infected her thoracotomy wound with her fungal infection, but yet she recovered from that and is doing fine. So certainty is the enemy of growth. We are all here today to think about things differently, so I'm excited to hear how we could use hybrid revascularization for women. Thank you.
Thank you very much. I think we have a few minutes for questions from the audience. Dr. Sarkar, I was personally quite alarmed with the increasing rates of ischemic heart disease. Could you maybe tell us a little bit why that is?
So are we, actually. I think our main problem is we are still not doing very well on the diabetic front. The metabolic preventive screening is not to the mark where it should be. And what I think we need to realize is the extent of under-penetration of treatment. Because we cannot be performing, like this year, we were doing an audit for the Indian Association, and in this year we would perhaps be somewhere near the number of coronaries that are being done in the United States, maybe nearabouts. I'm not exactly, can't get it down to the last hundreds. But the fact remains, it's not a question of poverty. The number of people with medical insurance in India is 4 times the population of the United States. Is 4 times the population of the United States with medical insurance, with the disease. We are lazy people. We do not know how to reach out and diagnose. So that is the challenge. We are putting our thinking caps on, because unless in the gamut of the next 3 to 4 years, we rev ourselves up to doing 400,000 coronaries per year, we will not be addressing the issue.
I think.
Sure. Hi, good morning. I'm Danielle Spragan. I'm a cardiac surgeon in Philadelphia. I have a question for the panel and maybe Dr. Pereira specifically. So I think you all did. The presentations were fabulous. Thank you so much. And of personal interest to myself regarding non-white populations in women. So I do have a specific question about non-white populations. So the panel's done a great job summarizing in women some of the etiologic factors, some of the things that are contributing to the disparate outcomes. So I'm curious about what you think about non-white and minority populations specifically. Why is there a difference in outcomes? For example, traditionally the prevailing theory has been lower SES, the social determinants of health, but that's been debunked as the only factor. So what is the main factor, or do you think one of the big factors that contributes to the discrepancies? Because it's really, in my mind, unacceptable that we just say this population does worse and that's that.
Yeah, I think it's really eye-opening, the number of clinical trials that really don't involve minority women in particular. I tried to find even more on non-Caucasian patients for this presentation, and there is really only about 3-4, trials. But I think that it's access to healthcare. I worked in Alabama and the South for many years, and the population was hugely underserved. And if you add minority status with women gender status, I think you see a huge, even additive discrepancy in access to care, and patients come in a lot sicker, and we need to do better.
And do you think there's a role for physician-patient concordance in terms of gender or race? Do you think that plays a role? Is that something that can help mitigate the differences? It's a big problem. I know we're kind of unicorns, but...
Absolutely.
May I add a comment about intraoperative findings? So I operate on a lot of patients of Asian or Indian descent, and perhaps you, of course, have a lot of experience with that. And again, I notice quite a significant difference in anatomical characteristics, where the lemur tends to be more thin-walled and often more adherent to the chest wall. And again, I think they're a population that need more careful and technically more expert surgery, and some of the worse outcomes can be related to a more challenging intraoperative situation.
Can I just ask you, is there any impression, experience, data from United Kingdom?
There isn't. In fact, I can't even convince my colleagues that there
The
are
only
harder
data I
group of
could fish
patients
out
to
was from
operate
Canada.
on.
Yes.
Yes, there isn't any.
Yeah.
It's not in the Euroscore. Being a woman is, but
Yeah.
being Asian isn't.
Maybe you could comment just briefly on technical size of suture, skeletonization of the mammary or not.
So I did my fellowship in Stuttgart, and when I came back, I was a real enthusiast about skeletonizing all the lemurs, and I have a very large cohort of Asian patients, and very quickly realized that in skeletonizing the lemur, often the lemur came out looking really quite sad. And I went to observe a surgeon called Dr. Bhattacharya. He's a very well-known coronary surgeon in India, and he does limited skeletonization, so he removes the fascia but maintains the vena comitante, and I thought that was a nice middle ground for these patients to sort of preserve the lemur while still partly skeletonizing and gaining the benefits of skeletonizing.
Thank you.
Question from the floor.
So just a comment regarding the issues of anemia and impact, and I congratulate Jennifer and Mario to bring that to our attention as potential explanations in this discrepancy between gender outcomes. But I want to make sure that we in the audience do not jump to the conclusion that the answer is a blood transfusion, because I think anemia is bad, no question about that, but anemia plus blood transfusion is worse. So we have done a study where we show that even under the circumstances of extreme anemia with a hematocrit of 18 on pump, a blood transfusion will result in worse long-term outcomes and survival than those individuals who had a low anemia of 18 without a blood transfusion. So the answer is non-transfusion mediated management of anemia.
Thank you. And Dr. Schwann has a very nice editorial that you could read about that also. Dr. Taggart.
Yeah, thank you. Just first to congratulate all our presenters. I mean, the super presentations. What I wanted to know, and I don't understand, when you say anemia is a risk factor for women in CABG, is it because the anemia is a surrogate marker for other problems rather than it being somebody very well but who's, just not been on a good diet? So is the anemia, as I say, is it a surrogate for some other problems?
That's a great question. It could very well be a surrogate for smaller size. And with all the amount of risk, adjusting, and we'll never be able to randomize women to men.
Yeah.
So it could very well be size.
Thank you again for the great presentations.
Thank you, everyone. I think there's a industry-sponsored luncheon right outside, just outside.